from Eli Lilly and Company, but today I'm wearing my DAC hat. And you have just heard from the first two work streams as part of the Davos Alzheimer's Collaborative, Rhoda and the cohort work stream, and John and the clinical trial work stream. And I'm pleased here to bring you the third work stream, which is on healthcare system preparedness, with a fantastic set of panelists who are going to give you some real world views as to how we translate the innovation that we're seeing in therapeutics and diagnostics into clinical practice. This is a perfect topic for Lausanne VIII. I mean, think about where we've come for the last 8 years, and the fact that we can really be talking about how we bring these innovations to patients is really exciting. So I'd like to orient you to where we're going to discuss today, and I'm going to bring up a slide that we call the patient pathway. So our healthcare system preparedness working group in 2020 took the challenge of how are we going to define success in healthcare system preparedness? What does good look like? And one of the challenges, of course, was each of us were defining the problem a different way. And so we took the time to very carefully define the problem and break it down into what we call digestible chunks or nodes. So the first node that we're attacking is actually on early detection of cognitive symptoms. And so hopefully you're seeing that slide right now. There it is. And you'll see it highlighted, that node in the middle. Now, why did we start there? We started there because we believe that that is the key to unlocking both sides of this patient pathway. When people realize that there's something that can be done, they're willing to have these conversations about symptomatic situations that they or their loved ones may be dealing with. And then when they learn about that, they actually start taking a better interest both in their brain health, as well as all the downstream implications of identifying those symptoms very early. So we've got 4 panelists today for you, and I'm going to introduce each one of them and let them spend a little time about talking how they're attacking this problem in their country. So one of the things that's really interesting about healthcare system preparedness is this is not a situation where the high resource countries have this figured out and everybody else is following. This is a problem that we're consistently facing around the globe. And actually, there's a lot of opportunity for high resource countries and low and middle income countries to work together and learn from each other. So I'd first like to introduce Otelo Correa. He's going to speak to the Brazilian public health approach to healthcare and its ability to implement routine Alzheimer's disease checkups for early detection and diagnosis. Otelo, over to you.
Okay. Hi, everyone. Something about Brazilian health system. Brazilian healthcare is provided by Unified Health System, SUS, Sistema Único de Saúde, which organizes and finances universal and free access to care for all legal residents of Brazil, with no cost to patients, and most prescription drugs are either free or heavily subsidized. A separate private system financed by health insurance companies exists alongside the SUS that covers around a quarter of the population, or around 45 million people. The public care delivery system is heavily reliant on primary care, which mostly provide in municipality-owned facilities. Primary care physicians serve as gatekeepers, and a referral is necessary for specialist consultations and elective admissions and procedures in the public system. Brazil is facing an important shift in terms of mortality at birth, age of birth, with the proportion of the population age 60 and over reaching 13% in 2080, which is expected to double in the coming decades. About 40% of dementia cases worldwide can be attributed to modifiable risk factors. This proportion may be even higher in less developed regions, such as Latin America, where the proportion of potentially preventable dementia cases has reached 56%. In the absence of a formal plan, memory care is planned and governed as part of a general health system coordination. There is a specific legal protection for the elderly statute. FEBRAS and ABRAS, the Brazilian Alzheimer's Association, represents the interests of patients with dementia and their families in the policy dialogue with municipal, state, and federal managers and advocates for compliance with the above-mentioned laws. The Federal Ministry of Health has issued guidelines for diagnosis and management of Alzheimer's disease that are debating for SUS facilities. Several professional associations have also developed the clinical guidelines for memory care. The prevalence of MCI in Brazil is 6.1% in population over 60 years and older, and 8.3% among subjects aged 65 years and older. Around 1.25 million Brazilians would live with MCI and around 1.5 million with dementia. With population aging, the number of Brazilians with dementia projected to triple by 2050. The DAC flagship project will assess individuals aged 60 years old older with complex of memory impairment residing in the municipality of Volta Redonda. Volta Redonda is a municipality of a state of Rio de Janeiro in Brazil. Through a digital cognitive assessment and for those with cognitive decline, biomarker blood tests for risk for amyloid plaques in the brain, so risk for Alzheimer's disease. It will be carried out with 10 medical resources in 5 public sector units linked to the municipal health department, 4 district-based health units, and 1 in the elderly polyclinic, all located in the municipality of Volta Redonda. Digital cognitive assessment will be administered, and those with cognitive impairment will be asked to provide a blood sample to assess the likelihood of amyloid pathology. The project is already approved by the local IRB. The contents of the training material for doctors is also being finalized. The units are selected. The doctors will be selected shortly. And the project's relationship with the municipal laboratory is also already defined in past week. Volta Redonda has a population of approximately 55,000 inhabitants over 6 years. And it's estimated that about 285 cases of Alzheimer's disease in early stage must be confirmed and referred to reduce risk factors and or for a possible disease-modifying treatment. The consequence of the project, in addition to provide results to be compared with other places where it's also being carried out and provide a basis for the expansion of the model for the AD, for Alzheimer's disease, we have 3 central aspects in my thought. 1, the consequence for the local health system, Volta Redonda, state of Rio de Janeiro, insofar as it proposed an organized model for early AD diagnosis, and will certainly encourage the continuity of the model, even with other diagnostic instruments, Minimental and CS5, for example. The consequence of disseminating the project and its results to other centers for the student care of people with AD, whether at the state level or in university centers, and for associations for the advocacy of people with AD, SUX, Febrais, and Abras. And third, the possible consequence for the central health system itself, which may be influenced by the results of the projects, the several projects, and by the possible implementation of similar programs, we encourage new public policies aimed at Alzheimer's disease. Okay, so my points at now.
Thank you, Otello. It's really fantastic progress. And I love that you mentioned how modifiable risk factors are contributing to the prevalence of the disease in Brazil. I think that really reinforces our selection of starting with early detection, because of course, if you can detect those symptoms, you have the opportunity to talk with patients and their families about those modifiable risk factors. I also have to thank you, Otello. You guys in Brazil are setting the pace for our flagship projects. IRB approval, training materials. It's really a testament to your passion for this project. So thank you for that. Two things that you brought up that I think were really important that you'll hear more from our other panelists as well. One, your partnership with your local ADI member, Fabraz, is just fantastic. But I think the thing that's really pulled through speed for you all is your partnership with the local municipality and having those government officials involved from the very beginning. So now I'd like to turn to Anna Borthwick, who's going to build on that concept of partnerships and stakeholders, having them all around the table. She's going to talk about Scotland's commitment to brain health and their partnership with the NHS health system and how that's bringing all the stakeholders to the table to make important decisions quickly and really be able to move Brain Health Scotland forward. Anna, over to you.
Thank you so much, Phyllis. I'm delighted to join you all today and to share the work that we've been doing in Brain Health Scotland over the past year. I thought it would be helpful to spend the next few minutes outlining our initiative and then how it relates to the DAC mission. So for those of you who may not be familiar with Brain Health Scotland, we were established in 2020 by Alzheimer Scotland, which is our national advocacy organisation, and we're funded by the Scottish Government. It followed personal endorsement from the First Minister of Scotland, and this support for improving brain health has featured in our programme for government now for the past 2 years. Our mission is to reduce the incidence of dementia in Scotland, and as Phyllis has said, we work in partnership with a range of stakeholders with the aim of broadening the conversation about brain health across the whole life course. We want to inspire people to think about their brain health and to consider ways they can protect and improve their brain health throughout their lives. So we hope to bring the brain health mindset to life in Scotland, and we work across 4 key areas. The first one is public policy. We want to see the principles of brain health and dementia prevention across public health, clinical practice, and the NHS as our healthcare system. The second is public understanding. We want to provide people in Scotland with all of the information, advice, and support they need to promote positive brain health. The third, naturally, is healthcare. We are leading a change in our healthcare services to engage people with the concept of prevention. We have a specific mandate to lead development of brain health services at a national level within our public National Health Service. And it's in these services that the DAC flagship project will be delivered. And finally, we work in research. We know that research is at the heart of a better understanding of brain health, and we want to help people in Scotland to take part in programmes that will change how we manage brain health in the future. So one of our key activities over the next 5 years, and the one which is most relevant to the DAC initiative, will be to develop these brain health services in the NHS, which give people access to risk profiling, early disease detection, and personalised prevention plans. Our vision is for these services to be community-based and housed within the Alzheimer Scotland resource centres, which you find on high streets and in community centres across Scotland. Currently, these centres provide support, advice and daycare services to people living with or affected by dementia. So this expansion is a new partnership between the NHS and third sector to provide these clinical services in the heart of the community. We plan to establish these over the next year. The entry point for people will be brain health hubs, where people can come if they have any concerns about their current or future brain health. Trained staff will be on hand, as well as self-directed health assessments and advice. If a person is deemed to be at medium or high risk, they will be referred on to a demonstrator brain health service within the NHS, where they will be seen by either a nurse or a consultant, depending on their specific risk profile. This will allow for more detailed cognitive and biomarker assessments, such as those being made available through the DAC flagship project, as well as brain imaging to determine the very best personalised risk reduction plan. It's important to note this service will also provide an open invitation to anyone who would like to get involved with research studies as part of our effort to improve participation rates. We're currently working with the Scottish Government and 5 of the 14 NHS health boards to establish this programme of demonstrator sites to test and prove our clinical pathway, and we plan to be operational in the first quarter of next year. So how has DAC helped us in this real-world setting? Due to the broader changes taking place within the NHS around these new services, the situation in Scotland is a little different from many of the other groups taking part in the flagship project. So instead of testing these new diagnostic tools within existing cognitive clinics or memory services, we're simultaneously building a new service aimed precisely at improving early detection rates across the piece. And I suppose it will come as no surprise that the NHS is under intense pressure at the moment, due not only to COVID-19, but also a culmination of funding, staffing and capacity issues. With winter approaching, this shows little sign of easing, and the system, it's fair to say, is pretty much on its knees right now. We are still facing significant challenges with delayed treatments, a lack of hospital beds, and morale among staff is low. However, the appetite and enthusiasm we've found for improving brain health are such that we're making really good progress. And I've identified sites already within these 5 NHS boards where our advocacy organisation can also support these proposed developments. Being involved with the DAC flagship has provided a really important global validation of our approach. And as we innovate locally, it's so helpful to be able to show partners in the Scottish Government and NHS that this movement is taking hold in other systems as well. We've also really benefited from the community of practice, which allows us to share our ideas and best practice and areas of challenge. And gaining an international perspective on these issues is a fantastic opportunity and one that we're really grateful for. So hopefully that helps to explain the context of where we've got to in Scotland. And I'll hand back over to you, Phyllis, for the rest of the session.
Thanks, Anna. It's just terrific. And I think, the conversations about how COVID has impacted healthcare systems is one that we're dealing with across the Davos Alzheimer's Collaborative. Certainly with our goal to make this that next Gavi or CEPI, we do need our healthcare systems with us. And Scotland, you're really leading to help bring NHS to the table. But if we in the DAC group can provide that seed funding for you all to be able to start that transformation more quickly, that's part of the mission. I think the other thing that you hit on was the late diagnosis. And we know that in Alzheimer's disease, one of our biggest problems is that people are diagnosed way too late. They're diagnosed too late to be considered for a clinical trial. They're diagnosed too late for the support services that their families desperately need. And they're going to be diagnosed too late when the disease-modifying therapies are available. And we really want to make sure that people who can benefit are able to. So you've pushed this earlier and into your front line through your brain health centers. And I'm going to actually turn it over here to Steve Smith from the US, because the US is looking at some of those same challenges. How do we shift this as early as possible? And in fact, have people take control of their own brain health? And so Steve Smith is going to explain how the US healthcare system is transforming the whole system from a direct-to-consumer pipeline, from more expensive resources to a scalable, low-cost DTC system. And I think we're going to start seeing some common themes coming up around the world about how we're tackling this problem. So, Steve, if it's okay, I'll send it over to you now.
Absolutely. And Phyllis, appreciate the introduction there. I serve as Senior Vice President and the Chief Scientific Officer for a company called Advent Health. Advent Health has 80,000 employees. We operate and provide for patients in 9 states, 53 hospitals, and almost 6 million patient visits a year just within our system. In the US, as you may know, there is a multiple payer system. We have the federal government system Medicare, which covers 65 and over. We have what's called Medicaid, which is administered by states, but funded in part by the federal government, and that's for low-income individuals. And then the majority of Americans today receive their healthcare through private insurance systems. Those systems, all 3 of those that I mentioned, have specific incentives for what physicians do in their practices. And as we look at primary care, which we believe is the real opportunity for identification of mild cognitive impairment early for the reasons that we've heard about, those incentives oftentimes don't provide the physician with the why for them making the time and effort to understand the patients in front of them and to screen for mild cognitive impairment. And that financial system is therefore misaligned. And that's part of the challenge that we have in the US. I was very interested, Anna and Otello, to hear, how you've been able to entrain the government very early into aligning incentives so that people can move in a singular direction. And that's a great model for us, we believe, in the future for working with both federal and state levels. But today, our approach with the Davos Alzheimer Collaborative is to try to make it easy for those physicians who are so busy in their office, who have many other grievous illnesses to care for. And prevention may not always rise to the occasion on a daily basis. So how might we make it easy? We have been scooping up ideas from our international colleagues in the Davos Alzheimer Collaborative and incorporated many ideas, including working through offices for primary care, creating vouchers for digital cognitive assessment, and then beginning to teach healthcare systems, the primary care in particular, how biomarkers might be included along with other assessments to identify patients that need to move on for more detailed assessments, particularly with neurologists, and to really engage the system that exists for patients today who have later stages of Alzheimer's. So what we want to do is to learn, as we are from the rest of the world, incorporate that to make it easy for physicians, and to basically systematize it within our primary care networks across the US as a means of early diagnosis. Now, one of the things that we're very passionate about at Advent Health is what we call whole person care. And that includes lifestyle factors, particularly the modifiable lifestyle factors that we all know contribute to the rising prevalence. And that is, a healthy lifestyle, including physical activity, very high quality diets, additional impact factors of rest and community and relieving stress. All of those are important to us in terms of how we care for our patients. And we feel very strongly that the earlier detection will allow us to use the tools that we already have within our system to manage those modifiable risk factors, including diabetes, obesity, and the ones that I mentioned earlier. Now, why are we doing this? We're really energized about the idea of being able to change the model in the US from one that is hard for physicians, that's not being used, and to create a new model that can be used on a go-forward basis. And that kind of implementation science, we believe, is going to be imperative to tackle this problem. Patients, we call them consumers now, have a need for this, and it's something that we're, again, very energized about. Back to you, Phyllis.
Thanks, Steve. That was a very positive overlook of our U.S. system and some of the challenges we face. But I want to thank you for your generosity and actually coming to this worldwide global table with us. Sometimes, the U.S. isn't so great about coming to this global community, and the Advent team has really embraced the community of practice and really, shared your learnings, learned from others, and pushed us. I think you've pushed us, which is fantastic, to think about how do we make sure these solutions are things that will work in our U.S. system. Your whole person care is something that is a remarkable vision, and I think it's something that the whole world embraces as well. We see this a little bit in the ICOPE project that the World Health Organization is running right now, and I think we can find some synergies with some of these other projects. And I think, like Scotland, you guys are taking this as more than just a pilot. You're going to jump in with both feet, and I think that's a fantastic thing that shows us how visionary the Advent leadership team is. So we're going to transition to something and build on something that you already talked about. This idea of misaligned incentives, this idea of task shifting, this idea of the fact that there's no one bad actor here, which is why it's not happening. It's a system problem. And so we're really lucky on our DAC team to have Soren Mackey, who's one of our probably biggest healthcare system experts in the field. And I'll use a little bit of American baseball analogy here, which is Soren's going to come and bat cleanup for us today, which for those of you that don't watch American baseball, it's the fourth batter, and it's the one that brings all the ones who are sitting on first, second, and third base home. And so that's what Soren's going to do for us today in our panel. You know, we are using implementation science as part of this project. And what does that mean? It means we're going to leave it to the regulators to evaluate the cognitive assessment tools and the blood tests and the scientists. We have processes for doing that. What we don't have is processes for looking at how these tools are utilized and what real world barriers do they face. And how do we look across these different initiatives, which are across very different healthcare systems, and look for those things that are global principles that really can be applied globally, but then still allow for local adaptation so that whatever solutions come out are customized and really culturally and operationally appropriate for each individual healthcare system. So Soren, can I hand it over to you to kind of tie up this conversation before we get to Q&A by confirming what things are we looking for around customizable solutions, our global infrastructure, and really these system challenges that we face with early detection?
Yeah, thank you, Phyllis. As many of you know, I've busied myself for the last few years looking at the preparedness of health systems for a disease-modifying treatment. And the overwhelming response was no country is really prepared for this because of the large number of prevalent cases that has been mentioned by Otello, for example, with existing MCI that would become eligible right at once. The thing is, after we started working on this, tools emerged like blood tests for Alzheimer's pathology, digital biomarkers. So the capacity constraints began to ease, in particular in the high-income countries, to a point where you didn't have to worry that much anymore about specialist evaluation and PET scanning capacity. But then it dawned on me. On what if they don't come? What if patients never ever show up to specialty care because their primary care doctors don't pick up on subtle signs of cognitive decline? The patients downplay it as signs of normal aging. There's really no great awareness on why it is important to intervene early and refer early. And this is sort of the birthplace of this particular node of the DAC Alzheimer's Collaborative, to get primary care systems or even pre-primary care systems ready to pick up these patients, to give them a new diagnosis of cognitive decline and refer them to appropriate treatment options that may be sort of risk mitigation, that may be disease modification or simple social care. But in all three cases, there are gains to be made. There is no point in nihilism to say it doesn't matter, we can't do anything. The solutions, like we've heard today, have to be very system specific, right? In a very regimented public health infrastructure in Brazil, you have to really work through the local governments that organize all of healthcare and get them on board to establish the structures by which patients get picked up and referred. In Scotland, it's also government run, but with a greater role of civil society in organizing services that lead into the NHS. And in the US, of course, creativity is the word. You can do pretty much anything if you make sure that the business case is there, and eventually the business case will be there. So I'm really encouraged to see all these solutions together with others in the world that pop up and give us guidance on how can we make it work in a given structure, and then see how does my system structure resemble that structure, and maybe I can pick up these solutions. Right? The idea, for example, of walk-in clinics for brain health emerged in South Korea, where you can just go into a memory clinic without appointment, you get a free cognitive screening, and then referral to appropriate resources. And it made its way all the way across the Ural and the Channel up to northern Scotland. So it's really amazing how these ideas promulgate if you have a platform like DAC to disseminate them. Back to you, Phyllis.
Thanks, Soren. We are going to shift to some Q&A. And so if people have questions, feel free to type them into the Attendify platform. I have a few here as well. Soren, before I let you off the hook, you kind of hinted at this at the end, which is our platform for sharing. So, of course, one of our goals is to share in the academic literature. That's what our scientists are used to. But we also know that in the public health space, that academic literature may not be the best venue. We have partnered with some implementation science experts, and we plan on having disclosures that also can be published through electronic means, through the web, basically toolkits that could be pulled down from individual countries to say, my health system's like this one, or my health system's like that one, or my idea is similar here. Do you have any ideas that you'd like to share, even to your fellow panelists, but certainly to those listening and watching, as to how we're going to make sure, because obviously we can't seed fund every healthcare system around the world, but how are we going to make sure that this information gets disseminated in a way that it can be utilized broadly?
Yeah, that's a very important consideration, Phyllis, because us academics often have great ideas and run them through a grant-funded mechanism and then we publish and walk away. Because for a researcher, there's really no direct incentive to make sure that the idea stays alive, let alone gets scaled. And so this is a very different endeavor in that the very purpose is to create ideas that live on, that are compatible with the health systems in the future and also compatible with other healthcare systems. But for that to become a reality, we need to transform research results into toolkits, basically what you say, guidance, process flows, standard operating procedures, or even just stories for people to learn, this is how they make it work, this is how they make it pay, and this is how they make it sustainable so that it doesn't die with the publication.
Yeah, and I'm going to turn this over to some of our other panelists, because I think one of the things that's unique about the grant, so many of you know that the DAC Healthcare System Preparedness issued our first RFP in October with concept papers due December 1st. And one of the things that's unique about that grant is we are not looking for academic institutions to apply for those grants unless they are partnered with a healthcare system. And what do we mean by that? We mean a real world healthcare system whose primary goal is to change their operational workflow so that what we're doing is seed funding that transformation. And Steve, I'd like to come back to you because you talked a little bit about this already. So when you think about the barriers in the U.S. healthcare system to cognitive detection, what are those barriers as you see them? And if you want to throw a facilitator in as well to give us hope, that's fine as well.
Yeah, so let me just hit the top three as we see them. One is the incentives being misaligned. I mean, we don't. Physicians in the U.S. follow the incentives financially, where do they get paid, where do they don't get paid. And increasingly, we have opportunities, I think, at multiple levels to re-incentivize physicians to work in this space. The second really is the busyness of our primary care physicians. I mentioned that earlier. I won't spend any more time on that. I would like to hear eventually from the other countries in DAC and how they handle busyness in physician. As I said earlier, we're looking to make it easy for the physician so that the enzymology, in essence, what the energy it takes to get over the hump is very small. I think the other barrier is really public awareness of the why for early detection. We live in the U.S. and many others are fortunately or unfortunately following us in a consumerism environment. And patients drive what they want or believe that they need. And I think we have an opportunity to overcome that barrier by educating the public at large, policymakers and governments as well, on the why for early detection. because most, at least here in the US, don't know that there are things that they can do to preserve their brain health should they begin into mild cognitive impairment. So I think those are really the key barriers. The last one, I think, is going to take really a big idea. It's going to take really the larger community. We're working on the implementation bottom up to make it easy and work, but that top down is going to be an imperative to drive in the US and other parts of the world patients into the system to ask for cognitive testing the same way they come and ask for cholesterol or a Papa Nicolau test or, other screening. We need to make the conversation as easy as that.
I think you're onto something there. We've done a lot of work on women in brain health, and what we know is those women are chief medical officers in their families, and they're often the ones that are help seeking for themselves as well as for others, and it does drive change. So Otello, I want to come to you because Steve kind of hinted at this. He wants to learn from other panelists. People here on the Lausanne call are getting to see what our communities of practice meetings look like. Steve talked about the primary care physician and how that physician can actually be a barrier because of how much they're doing. This is something that Brazil has thought about, and you guys have actually shifted the task. Talk a little bit about implementation in Brazil and specifically your frontline health providers that you're working with for the flagship project.
Okay. And the health unified system in Brazil is heavily based in primary care. And I believe this is the one point that Stephen talked about that I'm talking also. This is the point. The education program may be put together all the social actors for medical societies, academics, universities, advocacy associations, medical associations, geriatric association, neurology association, family medicine association. If we could put together those people, and if we have a huge education program, I believe it's the way here in Brazil to pressure the congressmen, to pressure the central government to agree our positions. This is the point, because the doctors are the great majority of the primary care physicians in Brazil are very young doctors. It's the doctors with an open mind. It's the doctors you can educate, you can discuss, you can bring to give a compromise with our ideas. So I believe we need to put together to make some, conferences, letters, Congress, meetings, I don't know, but something which can put together those people.
Well, and we hope, Otello, that we're going to be obviously putting together that in a global way using the DAC platform. Specifically to your flagship site, though, you're actually not using a primary care provider. You're using nurses. Is that right? Can you talk a little bit to that solution?
Yeah. Okay, I talked for
No, it's good. I think I just think there's some folks on the call that want to see some of these operational challenges.
That's it. It's the passion. Yes, I will work with 10 primary care physicians in 4 primary care units. In Brazil, you have basic health units. All these basic health units have primary care teams. The nuclear primary care teams is composed by one nurse and one doctor, one primary care doctor and family medicine doctor. In Brazil, we have a family medicine community association, and you have a lot of education huge project for family doctors. So this family doctors take care for child prevention, women prevention, men prevention, the most common disease. They take care of about 80% of the thing who goes to with a high level of resolution. So in Volta Redonda, we will work with 10 primary care physician, and we are talking now with the coordination of the primary care, and we are selecting now the people. I don't know exactly all the doctors, but it's in a good way, I believe.
Well, and we've heard this.
Next week I have some news.
We've heard this in the U.S. too, right? Nurse practitioners want to be more involved. Nurses want to be more involved. Often that they are really that first line of defense, talking with the patient, and potentially have a little bit more time to talk about these issues. So I think you're going to give us a snapshot into that. Mm-hmm. You know, Anna, I'm seeing that we have a couple of questions from the chat, and I'm wondering if you might want to tackle one of them, which is, what are the operational challenges that you all have faced as you think about setting up this flagship site? I mean, obviously you're doing it as part of a broader Brain Health Scotland, but specifically when you think about putting a digital cognitive assessment and a blood test into practice, what are the operational challenges? And don't be afraid to give us the stuff that's not sexy. I mean, that's really what this project is all about, is, you know, it's really hard to collect blood and ship it, right? I mean, so yeah. Tell us a little bit about those operational challenges so people get a flavor for what you guys are working on.
Yeah, absolutely. I feel like I should go and open my folder of stuff on my computer that's not sexy to talk about in presentation. I think you've hit the nail on the head. That was the first thing that came to mind when you asked that question. I think for us, it is some purely dry operational things about, you know, obviously blood tests happen in every clinic and every postcode around the country, but how we get people through the system to collect the blood, store it and ship it in the most appropriate way. That's just, one of the kind of logistical things that we're having to think about. For us, I think because we're at the stage of setting up these clinics, these questions are actually really helping us to push through in a very detailed logistical way. Actually, how can we address this across the board? You know, in one conversation, how can we make sure that we get this going? And it'll bring some conformity, I suppose, and that there's a huge amount of, even though Scotland's relatively small, there's actually a huge amount of variation in how different health boards tackle these types of issues. So I think by coming with a flagship project like this and saying, well, we have this opportunity, it's such, as I've said before, it's such an exciting opportunity and something that, to touch on some of the things that Stephen's raised about trying to make this easy for physicians and bring them something that just helps move them forward. These are two, in terms of the blood test and the digital cognitive test, those are two very obvious tools that tick those boxes. You know, this is just something that's there, ready to go, an easy platform to use. So they're excited about that. And actually, I think by having these conversations about, for example, how to store blood and ship it in a uniform way across these sites is actually a really, really helpful tool. So it is a challenge, but it's one that means we'll get to where we want to be quicker, I think.
And it's very real, right? I mean, we often talk about in supply chain the last mile. And certainly we see this in vaccine delivery. The last mile can be the hardest. And that's a lot of what you guys are doing. We have this wonderful innovation in diagnostics, but this isn't a situation where if you build it, they will come. You know, we actually need to programmatically find a way to move those things in.
Yeah.
Absolutely. So, Soren, we got a question about, strategies to overcome some of these challenges. As you look across the community of practice, there's two other countries that we don't have with us today, Japan and Jamaica. We have one more, Japan, Jamaica. Who else am I mixing? Brazil, Mexico, which three we don't have with us. But what kinds of commonalities are you seeing in strategies to overcome these challenges, either within our 6 flagship sites or across some of the other projects that you're working on?
I think the one theme that emerged even from that discussion was make it really, really easy for primary care physicians because, yes, they are busy. And there's a secret that interestingly enough, countries that rely heavily on primary care, like UK, like the US, like Brazil, actually have a relatively low density of primary care docs to population, which explains why they are so overworked. So we have to find a way to take as much work from them as possible, and also for them to triage people that need to have further evaluation as easily as possible. I think that that's sort of something that emerges from all these discussions. We also need community awareness, because if people don't ask, there will not be a response. Like if they don't voice their concerns, if they don't say, me or my wife is worried about my memory, I seem to forget more things, it's just not going to be picked up. Much like if you say, my left arm went numb, you're not going to be diagnosed for stroke if you don't bring it to somebody's attention. So I think that these two things need to go in tandem. And I think they're going to be self-reinforcing, because if people ask more, their physicians will get into a habit to inquire more, and vice versa. If physicians inquire, people start thinking about it. Is my memory as good as it should be? Am I losing some way of recollecting things? Am I leaving my keys everywhere and can't find them? And I think then we evolve naturally, in, like Steve mentioned, into a way that everybody gets checked for cholesterol when they come in, if they have reached my age. And so it becomes normal. It's not even thought about. It's just done when you walk into the office before you even see the doc.
Yeah, I think you're building definitely on Steve's point there about the consumer taking kind of hold of their own brain health. We see that happening a lot already, but also that powerful reinforcing mechanism. And I think you're cueing in on something else we hear, which is by doing this regularly, we reduce stigma, right? So now you're not coming in and being given a cognitive assessment because somebody's worried about you, or because something's wrong, or because you're weak or crazy. It's just part of something we do. We take care of every other major organ in our body on a regular basis. Why do we not take care of our brain? So I think that's a really good point. I have one question that I'll address, and then I'm going to give a final question to the panelists. So we did get a question from Canada about the dissemination plan. And I think, Saskia, you'll be pleased to hear all this conversation about consumers and having people living with dementia advocating for themselves. When I speak with women's groups, I often say, if you found a lump in your breast and you went to the doctor and said that you found it, and the doctor said, well, let's give it a year and see what happens. What would you do? You'd go find another doctor, right? And so we wanted people to have that confidence that when they come in and they say, doc, something's not right, the doctor doesn't say, well, I'm not worried about you now, because that's just worried well or a subjective cognitive complaint, that they take people's concerns seriously. I think on the other side, you asked about physicians groups. We don't have our Japan flagship group here, but they are really leading the way on working with the Japan Medical Society and making sure that all of their learnings, they're actually building this project together with those medical societies in Japan. So we're excited to see where the learning comes there. So panelists, we have a few minutes. I'm going to actually give you some opportunities for one last ask. And so the question I'm going to ask you to give back to the audience is, what would you ask of the audience? What is your call to action? This is a very, very unique audience. You know, this is an audience of people who have influence in their countries, whether that be through health ministry or advocacy or research or even in the physician community. What would be your ask if you're in charge of this global problem of early detection of cognitive symptoms? What would be your one call to action for this audience? Who wants to go first?
Okay.
Okay, Atello? Okay, Atello, go.
Steven, come on.
Please.
Hello. I believe that we have Stephen talk about the early detection of diabetes, hypertension, and I remember the early detection of breast cancer in the 70s. We are in the same stage with Alzheimer's disease. And it's a very important moment because the stigma, because what we actually can do to these people to address the more comfortable way to the people who are diagnosed with Alzheimer. Maybe me in this moment, I'm got a blood test and you have Alzheimer. Oh, I'm in Lausanne. This, I believe, is a very important 2 points: the education of primary care physician and work with the consequences to talk to people about their disease in their diagnosis.
Primary care, and have a soft landing spot for people with that have just received this information. Anna, you want to go next? Steve, I'll let girls go first.
Yeah, thank you very much. I think it's to pick up on a note that you'd put out there, Phyllis, about the widespread awareness of what is possible, because we've been doing a lot of work in Scotland about where the current population are, the population at large, and their understanding of brain health. And although they are as concerned about their brain health as they are about the risk of cancer and heart disease, 25% of people in Scotland cannot name a single thing that you could do to protect your brain. And I just feel we need to shift that dial. So I think if people are in positions of advocacy, of engagement, of awareness raising, I think just raising the tide of how people think about their brain, and whether it's actions they can take in their personal life or opting into a health service. You know, many of us are talking about services that people are going to have to come to. They're going to have to volunteer themselves to come forward. And we need to make people feel confident and good about that they're going to get accurate information and helpful advice following any kind of diagnosis. So I think what we can do in that space is really critical to the whole movement.
Terrific. And I should have mentioned that you guys are also an ADI member, and we're really happy to have ADI as strategic partners for us on this initiative. Absolutely. Because Alzheimer's Disease International has those members around the world that can help make sure that support services are in place. Steve, what's your call to action for this audience?
It's actually very simple, Phyllis. It's one message, two audiences. Early detection matters. The two audiences are the world, our consumers that we care for in healthcare systems, and all physicians, not just primary care. I think once we get the physician community to understand early detection matters, then there will be more action on the part of healthcare systems and physicians.
No, I love that answer. And I think of the families that get this diagnosis in an emergency room because some accident has happened, and they are now facing a financial crisis that could have been prevented if that family had had the support services. And when we think about like the United Nations and the social determinants of health and our sustainable development goals, the families that are most vulnerable are the ones that are least able to get that surprise diagnosis. And so I think your point about all physicians there is really, really important, because there are things that we can do to put support around families for this progressive disease, which unfortunately is very predictable in its progression. And catching it early means we can help catch those things sooner and potentially help modify both their risks as well as the outcomes. So I think it's a great point. Soren, do you want the close?
I want to pile on Steve's comment here. I would want to reach out to those in charge of sort of high-level decision-making, be it at the government or executive level in charge of healthcare systems, to just tell them, like, make it a bloody priority that early detection happens. It's sort of odd that in the US we are spending so much money on healthcare, but kind of ignore one of the areas with the greatest unmet need, which is brain health at the moment. I mean, look what we do in oncology and cardiac care compared to that. Brain health is at a ridiculously infant stage. So make sure that early detection gets paid, for starters, because otherwise it doesn't get done. If this is a fee-for-service system like the US, make sure that there's a billing code. If this is a sort of government-run system, make sure that this is sort of in the realm of things that fall into the catalog that physicians need to do. But then conversely, also hold physicians accountable. Look at whether they are diagnosing patients, because we can predict in your panel how many cases of MCI you should have, how many cases of dementia you should have given your age and sex distribution. And if your diagnosed cases are just about 10% of that, we know that there's something wrong. And we can tell these physicians that they really need to look harder because they're not doing a good job for the health of their populations. And if we sort of get that push and pull from the top down into primary care settings, I hope we can sort of resolve some of the unmet needs, and I hope we can do that soon.
Yeah, I think that top down, bottom up is exactly the same visual that Steve gave us earlier, right? So each of you are operating on the ground in a way that we can really show how we bring this to life. But then I think this is my call to action for our audience, is that we have the World Economic Forum, we have the CEO initiative, we have our Davos Alzheimer's Collaborative. We're going to need to drive this top-down messaging and making sure that that narrative is there, both locally and globally. So I think my one ask for this group is to phone a friend. The biggest challenge we have for DAC right now is that people don't know who we are. They do not know these resources are here. They do not know that we want to help. We know that, especially in the time of COVID, but even outside of COVID, most healthcare systems around the world are really struggling just to make do with the resources they have. They need seed funding to shift their population health, to shift their workforce and their workflows so that they can really manage for innovation. So let someone know this project is here, direct them to our website, direct them to the RFP. We're not going away. This is our first RFP and first grant for this first node, but we've got 9 more to tackle. So that's my question. That's my request, my call to action for the group. And I just want to say the biggest thank you to all of our flagship sites, but especially to our panelists today. You guys are such a joy and pleasure to tackle this problem with. And I'm going to hand it back over to George Vredenberg for the next panel.
Thank you, Phyllis. Thank you, Phyllis, and thank you to all of our Davos Alzheimer's Collaborative partners on this panel. It is intriguing to see how much progress has been made in thinking about this aspects of the last mile, which is so critical to actually be able to engage patients, the people that we're most concerned about, the populations that we serve. How much progress has been made on this project since we launched the Davos Alzheimer's Collaborative less than a year ago in virtual Lausanne 7 and Davos 2021. So very much appreciate all of your work and the fact that you're becoming champions of this effort and that we can extend this reach of this last mile effort beyond the flagship projects and into health systems more generally through our Davos Alzheimer's Collaborative Learning Lab. I hope next year, by the time we come to next year in Lausanne 9, we can provide a larger set of concrete results on these pilot programs that you've just heard about and have successfully recruited many more healthcare systems around the world to partner in these efforts and then to participate in a learning system that enables us to affect many more health systems than we actually ourselves finance in terms of their change.